ये क्या दे रहे हैं?
अब यहाँ से भी नहीं बोल रहे। अब यस, minimize this.
एक और चीज़ ये बताओ, जैसे आपने यहाँ से गो लाइव बोला है ना, यहाँ से गो लाइव
यस,
है ना, तो कैन आई डू इट फ्रॉम हियर? नहीं, यहाँ से नहीं होगा।
ऑटो
यूट्यूब
स्टार्ट बंद है तो वो यूट्यूब से होगा.
ओके.
You start streaming and then you hit go live over there. We are gonna see how it's coming up.
So yeah.
Your channel's name is Mandeep Singh.
Mandeep Sond here on here.
So this is what it's gonna look like, and I'll set it to max resolution possible. I think आपने ऑडियो बंद करी है क्या उसकी? This is what it's gonna look like, and I'll set it to max resolution possible. I think आपने ऑडियो बंद करी है क्या उसकी? वो थोड़ा This is what it's gonna look like, and I'll set it to max resolution possible.
So hello everyone, this is Dr. Mandeep. I'm a pharmacology faculty at Nixtelo. So today's YouTube live is about drugs for heart failure. So yeah, let's start with this. There's your heart flowing. So the flow of the discussion would be like, first we would have the overview of heart failure, then we would go towards the pathophysiology, then we would discuss the effects of neprilysin, sympathetic nervous system, angiotensin 2, and aldosterone. Once we are done with that, we will go for discussion of each class of drug used for chronic heart failure, and then we will discuss the questions and answers. Obviously, for questions, you can go to the comment section of this live and post your questions there. We'll discuss them towards the end of the video, right? So yeah. So what's the definition of heart failure? So most of the heart failure that we are going to discuss is chronic heart failure in this video. So, any alteration in structure or function of the heart which impairs the pumping of the heart will be heart failure. So, what it does is it produces symptoms of heart failure whenever we put stress on heart. It leads to number of signs and symptoms on in the individuals who are suffering from heart failure due to loss of function, right, due to structural or functional abnormality, that is called heart failure. So abnormality of heart structure or function or both, and symptoms of heart failure which are present at rest or stress. So what is the etiology of heart failure? Heart failure is usually divided into left-sided heart failure and the right-sided heart failure. So for left-sided heart failure, the most common etiology is coronary artery disease, and then there are other toxic cardiomyopathies such as alcohol-related cardiomyopathy, um, dilated cardiomyopathy, which could be due to stress or vitamin deficiencies also. And then there is right-sided heart failure, With right-sided heart failure, you would usually expect that it is due to chronic obstructive pulmonary disease, pulmonary embolism, pulmonary valve stenosis, or there are more uncommon reasons. And one of the important causes for right ventricular heart failure is right ventricular MI. As we discussed, the most common cause of heart failure is coronary artery disease. So yes, what are the signs and symptoms of heart failure? As you can see on the screen, we have an old man who has put his hands on his thighs because he's short of breath and fatigued. Then there are people who experience swelling in various parts of their body, including legs, face, or their belly. So in clinical medicine, we would regard this as like pedal edema, abdominal distension in the form of ascites, raised JVP, or shortness of breath could also be indicator of pulmonary edema, cross pulmonary edema, usually seen in acute heart failure, not chronic heart failure. So, patients with chronic heart failure also report that they have difficulty lying down in bed. Obviously, this is because when the patient lies down, most of the blood is directed towards the chest. So, the hydrostatic pressure in the capillaries of the lung, it rises and it filters out more fluid into the alveoli, making person short of breath when they lie down. Well, before this happens, there are certain patients who would tell you that they were lying in bed comfortably at night and then suddenly they were feeling choked and they had to get up and open a window, and that is called paroxysmal nocturnal dyspnea. So yes, one of the few symptoms that you would see in a patient of chronic heart failure would be shortness of breath, pedal edema, abdominal distension, raised JVP, fatigue, and these could be non-specific. But yes, someone who has had history of coronary artery disease in the past and is presenting to you with these complaints, you suspect heart failure. So how do you make the diagnosis? So diagnosis is usually in the form of firstly suspicion on the basis of signs and symptoms and lab tests. One of the few common lab tests that is used for heart failure is BNP, right? And there is a imaging investigation, imaging that is used, that is echocardiography. For BNP, what is BNP? It is brain natriuretic peptide. It is secreted from the ventricles when once they are stretched, or if the heart is failing, the BNP would be secreted from the ventricles, and it is high in patients of heart failure. Let's just say somebody has symptoms of heart failure and you order BNP. So if it comes out to be normal, the possibility of that person having heart failure is very less because BNP is a sensitive test. So if it comes out to be negative, the possibility of heart failure in that particular person is low. The second important investigation, rather an imaging investigation, is echocardiography. In echocardiography, you would assess the ejection fraction. Um, the particular subset of patients about whom these drugs would be discussed in the video would be patients with ejection fraction of less than 40%. Less than 40%. And that is called heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction. So, what's the pathophysiology of heart failure? So, as we mentioned, the most common cause of heart failure in current scenario is myocardial infarction. In myocardial infarction, there is complete occlusion of the coronary arteries, which blocks the blood supplies to the heart muscle, and it irreversibly injures the heart muscles. And once they injure irreversibly, what happens is injury leads to inflammation, and inflammation leads to fibrosis. So yes, in fibrosis, extracellular matrix and collagen is deposited in the injured tissue, and instead of muscles, there is fibrous tissue present in the heart. Excuse me. So once the myocytes or the heart muscle is replaced by a fibrous tissue, you would obviously, it is intuitive to think that those extracellular matrix and collagen is non-contractile tissue, and any more stress given to the heart for in the form of, let's just say, increased heart rate, increased exercise, or any other stress which would require them to contract more vigorously, won't be there, right? Because the myocytes have been lost. And another important point to consider is that whenever there is extra amount of blood present, because the heart is unable to pump the blood because of fibrous tissue, it would create a stretch in the heart muscle, the existing heart muscle. So what would they do? The existing heart muscle would be stretched, and it would give them a signal so that they undergo hypertrophy to increase the strength of and force of contraction. So as hypertrophy progresses, the blood supply is already compromised. The blood supply is already compromised, and there is fibrous tissue. So it becomes a vicious cycle where it is hard. It's already hard for the blood. Hard for the heart to pump blood, and with extracellular matrix, fibrous tissue, and more muscle fibers to supply blood, it is going to go into a downward spiral where would heart progressively fail to pump more blood despite trying his hard, right? So most commonly, obviously, left heart failure, there is laydown of fibrous matrix, leading to uh, hypertrophy, including progressive heart failure. This leads to dilation of the ventricular chamber. And as the ventricular chamber dilate, it also becomes thin because there is fibrous tissue, not actual muscle, as it dies out. And this leads to heart failure. Now, the deposition of extracellular matrix and collagen is not only the contributor towards heart failure, but there are a number of chemicals involved. What are those chemicals? Those chemicals are angiotensin 2, that are aldosterone, and another one of chemical is norepinephrine. Because whenever the heart is failing and our body tries to compensate, it would increase the activity of sympathetic nervous system. So once the sympathetic nervous system is active, what it would do, it would increase more release of norepinephrine from sympathetic nerve endings. So once that is released, it leads to a number of changes that includes remodeling. That remodeling is also mediated by angiotensin 2, angiotensin 2, and also aldosterone. So let's discuss more about pathophysiology. So angiotensin 2 would be the core of a discussion of heart failure, especially chronic heart failure. So angiotensin notion is synthesized in the liver, and then it becomes activated by renin. And where does renin come from? Renin comes from juxtaglomerular apparatus in the kidney. Why does that get released? Whenever there is a failing heart, the cardiac output would fall. That decreased cardiac output would decrease renal blood flow. Once renal blood flow decreases, the delivery of sodium to the distal tubule decreases, and this would release renin, right? So renin release cleaves the angiotensinogen into angiotensin 1. So this angiotensin 1, it circulates into the pulmonary capillaries, that where the endothelium cleaves angiotensin 1 into angiotensin 2. This angiotensin 2 obviously is formed by the enzyme called angiotensin 1 converting enzyme, and this is one of the targets for chronic heart failure. So the angiotensin 2 has a number of effects on body, that is for one of that is vasoconstriction, other is cardiac remodeling, and it also leads to secretion of aldosterone. So what does aldosterone do? It increases sodium in retention, water retention, excretes potassium, magnesium. So aldosterone in itself also contributes to cardiac remodeling, and there are receptors present on heart for aldosterone and angiotensin 2, and also on blood vessels. Let's go towards another discussion. Role of sympathetic nervous system. So sympathetic nervous system, as I spoken before, it increases cardiac stress, and there are two key events that happens with the increased activity of sympathetic nervous system. One is catecholamine toxicity, another is beta receptor dysfunction. With catecholamine toxicity, what it does, so as the amount of norepinephrine released from the sympathetic nerve endings is increased, heart rate would increase, and this would require more oxygen. With already compromised blood supply and fibrosed heart, it becomes difficult for them to coordinate. That is, increase in heart rate and force of contraction, because there is already fibrous tissue present in that. So increased stimulation leads to contraction of already present cardiac muscle fibers, which are overloaded with calcium. That overloaded calcium keeps them in a state which leads to oxidative stress. And also, as more norepinephrine released, that norepinephrine is a vasoconstrictor, and coronary arteries, they constrict in response to norepinephrine. And there is some role of mitochondrial dysfunction and increased permeability of mitochondria, which leads to cellular damage. And second thing is beta receptor dysfunction. Once heart failure sets in, there is decoupling of beta receptors in the heart. What does decoupling mean? So decoupling means that even if you stimulate the receptor on the cardiac muscle, the response won't be seen. It is because the second messengers of the receptor, they have been silenced. Also, the number of beta receptors on cardiac muscles, they decrease. The number of beta receptors, they decrease. So this is the effect of sympathetic nervous system after heart failure has set in. The next would be effects of neprilysin. So, as we discussed previously in the video, whenever the heart is failing or there is extra amount of blood in the heart, it leads to stretch of the cardiac muscle. That stretch of the cardiac muscle, especially atria and ventricles, releases certain peptides. What are those peptides? Atria releases atrial natriuretic peptide, and while ventricle releases BNP, that is brain natriuretic peptide. These peptide, as the name suggests, they cause natriuresis. So what does natriuresis mean? Natriuresis means that the elimination of sodium and water from the body. I'm sorry. Yeah, thank you. इधर होगा नहीं वो उसी से ला दो प्लीज thank you. So yes, neprilysin, what it does is ANP and BNP, as we were discussing, atrial natriuretic peptide and brain natriuretic peptide, they cause natriuresis. They eliminate sodium and water from the body. Also, these are counter-regulatory mechanisms. To decrease the volume status, and also they cause vasodilation. And they decrease endothelial cell permeability, and they are anti-angiogenic, anti-fibrotic, and anti-inflammatory. So here you can see synthesis of natriuretic peptide, ANP, BNP, and CNP. They cause diuresis, natriuresis, vasodilation, BP reduction, inhibit smooth muscle proliferation, also reduce renin and aldosterone release, and reduce fibrosis and hypertrophy. And the effects of angiotensin 2. So angiotensin 2, as we discussed, it is synthesized through a variety of chemical processes that occur in the body, finally in the lung, where angiotensin 2 is produced. Angiotensin 2 has two receptors. So one is angiotensin 81 and other is 82. So 81 receptors are responsible for the pathological effects seen in heart failure. The pathological effects seen in heart failure. So 81 receptors, what do they do? So they increase the sensitivity to catecholamines, they increase the sympathetic activity, increase sodium and water reabsorption, lead to increased amount of aldosterone secretion in the body, also promote release of ADH from the posterior pituitary, and they lead to increased expression of genes which increase fibrosis and inflammation, and these lead to heart failure. Now let's go towards the particular effects of angiotensin 2. So angiotensin 2 has 81 receptors on the efferent arteriole. The efferent arteriole. Here you can see like this efferent arteriole has an 81 receptors. 81 receptors. So as the amount of angiotensin 2 increases, the efferent arteriole constricts. So as the efferent arteriole constricts, the pressure in the Bowman's capsule rises, and this leads to renal injury. This leads to renal injury, and this is one of those principles used in patients of heart failure with diabetes, where we want to prevent nephropathy. Right, nephropathy. It is because the constriction of the efferent arteriole that rises the capillary hydrostatic pressure in the glomerulus leads to damage. And this principle is also very important because let's just say a patient has renal artery stenosis. Especially bilateral renal artery stenosis, or patient who doesn't have much fluid in their system. It means their BP is low or they are dehydrated. So what would happen is the efferent arteriole is maximally dilated so that the flow in the glomerulus is maintained. It's the flow of the efferent arteriole that is maintaining the pressure in the glomerulus, and which would lead to filtration of blood, lead to formation of urine, and this is maintaining the urine output or the filtration process. Once you give an angiotensin 2 receptor blocker or an ACE inhibitor, what would happen is the efferent arteriole will dilate. And the glomerular pressure will fall, and this patient would have acute kidney injury. So this can happen to all patients with who are hypovolemic, dehydrated, who has bilateral renal artery stenosis, are given ACE inhibitors or angiotensin receptor blockers. Those patients can land in acute kidney injury. So these conditions are a contraindication to angiotensin 2 receptor blockers and ACE inhibitors. So let's study the effect of aldosterone. So aldosterone acts on principal cells of distal convoluted tubule. So it's a mineralocorticoid. The mineralocorticoid is synthesized from steroids. So steroids are lipid soluble molecules, right? So what it does is the aldosterone, it goes inside the principal cell of the distal convoluted tubule. It increases the gene expression for epithelial sodium channels and potassium channels. So as the epithelial sodium channels increase, the absorption of sodium increases and the excretion of potassium increases, because it creates a negative potential here on the tubular side of the lumen of the tubule. If this is negatively charged due to absorption of sodium, it would derive potassium into the tubular lumen, right? And then there is sodium potassium ATPase pump, whose expression is also increased after aldosterone. Now Aldosterone not only affects the principal cell, but it also affects the alpha intercalated cells. So, as mineralocorticoid receptors are present inside the cell, aldosterone enters these cells, they would increase the expression of gene expression of which channel? Hydrogen ATPase. This hydrogen ATPase is responsible for excretion of hydrogen ions or acids from the body. Right? So, let's go towards the first drug category, that is angiotensin receptor neprilysin inhibitors. So this category has only one combination. That one combination is sacubitril plus valsartan. So why does this combination just one combination? It is because most of the research that has been done in the past few years on chronic heart failure is only on this combination, and even if they did some newer drugs, they they found out more side effects or they were not effective. So this is the only drug that has been approved for chronic heart failure. Which chronic heart failure? Heart failure patients with reduced ejection fraction of less than 40% who are stable. So yes, since it is a combination of angiotensin receptor neprilysin inhibitor, it means sacubitril is the neprilysin inhibitor. As we know that neprilysin is the one that cleaves ANP and BNP, ANP and BNP from the blood. Sacubitril will inhibit this neprilysin and will increase the level of ANP and BNP for that person who's taking this drug, and which would give the beneficial effects of ANP or BNP in patients with chronic heart failure. It is to be noted that patients who are on combination of sacubitril and valsartan and they present to you with acute heart failure or symptoms of heart failure, recent worsening of that, if you measure BNP in them, it would be high. Why? Because you are already giving a neprilysin inhibitor, which is sacubitril, right? So it is important to note that ANP and BNP would be falsely high in patients taking sacubitril because it inhibits the lysis of ANP and BNP. As with ACE inhibitors and ARBs, we discussed that if you give ACE inhibitor or ARB to a patient who was volume depleted, who has bilateral renal artery stenosis, who has hypovolemia, this would land them in acute kidney injury. Other important points to be noted are the angiotensin, the neprilysin inhibitors, they increase the level of ANP and BNP. This also leads to increased chances of angioedema. Because we are also blocking angiotensin receptors, potassium excretion is affected. There are more chances of hyperkalemia. So it is important that you have renal function test in the form of blood urea and serum creatinine before initiating sacubitril or valsartan. Then ACE inhibitors. So all ACE inhibitors are approved for chronic heart failure. They are the inhibitor of angiotensin converting enzyme, which is present in the capillaries of endothelium of capillaries of pulmonary circulation. And then, as we know, angioedema, kidney injury, and hyperkalemia are common side effects. So, with regards to ACE inhibitors, when we inhibit the enzyme, angiotensin converting enzyme, it is also responsible for degradation of bradykinin. So when you inhibit angiotensin converting enzyme, the bradykinin content of the blood increases, and this increases the risk of angioedema. Angioedema usually presents in the form of lip swelling or facial swelling, and which can be dangerous and life-threatening. So any patient who develops ACE inhibitor induced angioedema or angiotensin receptor neprilysin related angioedema, they shouldn't be prescribed these drugs. Instead, give them angiotensin receptor blocker, that is ARB. The chance of angioedema with ARBs is minimal, although it is there. It is important to educate patients who are given ARBs after angioedema with ACE inhibitor or ARNI, that the chance of angioedema would be less with ARBs, not nil, right? So let's go towards angiotensin receptor blockers. They are blocker of AT1 receptor. As we discussed previously, it is the AT1 receptor that is responsible for the most pathological changes in chronic heart failure. While AT2 receptors, they have a positive role. They are they do exactly opposite of what AT1 receptors do. Since we have already discussed what the AT1 receptors do, won't be easy to guess what AT2 receptors do. Obviously, they are antifibrotic. They inhibit cardiac remodeling. They cause vasodilation, right? So yes, angiotensin receptor blockers, they block AT1 receptors, as discussed with previous drug categories. They are they are prone to cause acute kidney injury, hyperkalemia. Obviously, the risk of angioedema is there, but it is very less as compared to ACE inhibitors or angiotensin receptor neprilysin inhibitors. Then we come towards beta blockers. But before we discuss beta blockers, let me tell you with regards to research, as we discussed in ARNI, that is angiotensin receptor neprilysin inhibitors, beta blockers were also researched. Amongst beta blockers, 3 were found to be effective in heart failure, especially chronic heart failure with reduced ejection fraction, that is EF less than 40% or 40%. These are, first is bisoprolol, second is carvedilol, and third is metoprolol, sustained release metoprolol succinate. Right? These 3 beta blockers were approved for chronic heart failure, those patients with ejection fraction of less than or equal to 40%. Yes. So there are certain things that we need to make sure that before we prescribe beta blockers to these patients. First, these patients shouldn't be in acute heart failure. Patients who are in acute heart failure, if they are prescribed beta blockers, it leads to worsening of heart failure. It is because in acute heart failure, there are compensatory mechanisms in the form of increased heart rate and force of contraction. If you block those, it would worsen the symptoms who are trying to compensate with heart rate and force of contraction. So yes, similarly, as we know, beta receptors are also present in blood vessels, especially of the limbs. If we block beta receptors, especially in patients with limb ischemia, it could lead to vasoconstriction and it could lead to worsening of that. Third important contraindication, as we in case of beta blockers, is heart blocks. So any person with high grade AV block. What do I mean by high grade AV block? High grade AV block means third degree AV block or second degree AV block, Mobitz type 2. Second degree AV block, Mobitz type 2. These 2 heart blocks are high grade AV blocks, and these are contraindications to beta blockers. So yes, also patients with chronic obstructive pulmonary disease, they should also be given beta blockers with caution. And then there are certain beta blockers which can be given in them, especially nebivolol. However, it has not been fully tested for heart failure. With the current discussion, the only 3 beta blockers that we need to concentrate is bisoprolol, carvedilol, and sustained release metoprolol succinate. Yes. This table mentions different beta blockers in which clinical scenario to use. For hypertension, you can use carvedilol and nebivolol. For COPD, you could use bisoprolol and nebivolol. Bisoprolol, it is because it's very cardioselective. Nebivolol, it is because it has additional nitric oxide releasing capability, leading to smooth muscle relaxation. And with diabetes, you can use carvedilol or bisoprolol. Similarly, with atrial fibrillation, you use metoprolol or bisoprolol. And these lists can be found in the book as well as online. Now, an aldosterone receptor antagonist. So, the two most common aldosterone receptor antagonists that we use in chronic heart failure, that is heart failure with a reduced ejection fraction, EF less than or equal to 40%. These are spironolactone and eplerenone. So these two drugs, they obviously, as the name suggests, they block the receptors of aldosterone. They block the receptors of aldosterone. Obviously, in which cells? Renal tubular cells, that is principal cells of distal tubule and alpha intercalated cells. And what these cells do? They increase the absorption of sodium, increase potassium excretion, and also excrete acid in the form of hydrogen ion, which combines with other ion to be excreted in urine. So these drugs, they have important side effects as discussed, because we are blocking their action. There would be hyperkalemia. There would be hyperkalemia because the excretion of potassium is dependent upon sodium, and we are blocking the receptors causing that. So there would be hyperkalemia and acidosis. So I think that is it. And before I start with question and answers, let's summarize all of this. So we were discussing that we chronic heart failure is something which is due to structure or function, abnormal structure or function of the heart, which leads to symptoms at rest or exertion. It is usually diagnosed on the basis of lab tests in the form of BNP or an echocardiogram. And then there are different etiologies for such heart failures, and then there is pathophysiology and the role of angiotensin 2, aldosterone, cardiac remodeling, and all of that. And then there were different categories of drugs, including angiotensin receptor neprilysin inhibitors, beta blockers, and then ACE inhibitors, ARBs, aldosterone receptor antagonists, and SGLT2 inhibitors. I think that is it for the video. If you have any questions, let me know. God, I was.
For some reason, you did not get the chat right.